excited. You know, we have somebody on our board who just joined our board recently, Josie, and she is a oncology nurse, and she hooked me up with this wonderful new friend, and it is Dr. Dao who is joining us tonight. How are you doing, Dr. Dao?
Great, thank you. Glad to
So
be here.
so great to have you. I'm really excited about this. You know, usually on the show we have a breast cancer survivor and a musician, but tonight is all about breast cancer survivors and having a breast surgeon here and then a survivor is going to be a great night. So I know there's a lot of survivors watching us tonight. We have a lot of folks here, Dr. Dow. So I'm super excited. We're going to have
Great,
fun,
thanks. Me
man.
too.
Yeah. So tell everybody a little bit. You know, when we talked yesterday, I was like, well, do you do reconstruction? What kind of stuff do you do as a breast surgeon? So fill everyone in real quick, if you wouldn't mind, on what exactly you do as a breast surgeon.
Oh, great. Um, that's I'm a breast cancer surgeon, so I focus mostly on breast cancer surgery, including like lumpectomies, mastectomies. So usually patients see me when they're getting diagnosed with cancer or evaluation of a new mass, or sometimes they just need high risk counseling for family history or worried about breast cancer. So I take care of all those things or anything you can think of as far as like also not just cancer, but also benign diseases, anything like a surgical diseases of the breast. So, I take care of people with infections and other issues or abnormal mammograms, things like that. So I take care of everything, but the main focus is breast cancer.
Gotcha. And so, like, if somebody had, like, I had fibroid cysts, like a lot of fibroid cysts, would you care for someone like that as well?
Yes, I would. I mean, I think a lot of patients think I just do breast cancer. So when they come in with like a fibroid cyst, they're wondering if something, somebody didn't tell them something. And I'm like, no, no, I see benign things too, meaning just, patients who have cysts in their breast who may need get something drained or aspirated, or even a new mass that may be benign but doesn't may need to be removed because it's getting bigger, that those kinds of issues, or even patients who are breastfeeding and have issues in that area. So kind of a whole broad spectrum of things.
Wow, that's really good to know. And it was funny because like we were talking yesterday, I was like, oh, so I'm gonna ask you all these questions about reconstruction because I didn't recognize that there was a difference. I myself, I didn't have reconstruction, so a breast surgeon's a breast surgeon's a breast surgeon to me. So I thought you did reconstruction, but that's usually done by a plastic surgeon. Is that correct?
Correct. So the things that I don't do, kind of that you alluded to already, is kind of like breast reductions. Those are going to be things more the plastic surgeons perform, or reconstructions, meaning um, implant tissue expanders or any kind of flap reconstruction where they put tissue or rearrangement, things like that. But I do a small part of plastic surgery where I do recreate defects. So when I do a lumpectomy, I do what we call kind of oncoplastics, which is new. It's been recently developing over the past few years where we can rearrange the breast tissue and recreate the breast. That way, we don't see a big defect after the surgery. And hopefully, I try to kind of keep the form of the breast the same so it looks like I wasn't even there.
You know, and I can really have a really big appreciation for that. You know, my breast surgeon, when I had my double mastectomy, that was kind of his goal too. And, you know, I opted to not have reconstruction. And, you know, I remember whenever I first saw my scars thinking, wow, this is, you know, they did a really good job. It just kind of, I mean, there's scars, but it just kind of looks like, you know, where my breasts were, it was just gone. There was no excess, you know, fatty, you know, areas or anything like that. It's just really nice and clean. And so from all of us out there who had those good experiences, thank you so much
Oh, you're very welcome.
for doing you know, for doing such a good job at that kind of thing, because that can be really a scary time for a woman going through something like that. You know, as I mentioned before, I didn't have reconstruction, so a lot of those types of things I'm not very familiar with. And some of the questions that we got from our board members when I let them know that you would be joining us tonight were things like, how do you go about determining if a person is a good candidate to have reconstruction at the same time as their mastectomy? Is that something that you're privy to, or is that something that the plastic surgeon determines, or would
Oh,
that be you?
sure. Yeah, I'm a part of that conversation. And for the most part, I think most people or most patients are a good candidate for breast reconstruction. The things that would we would watch out for, or patients who have a lot of comorbidities or a lot of medical problems that would make it difficult to have multiple surgeries, because the a lot of patients don't realize when you're having reconstructive surgery that sometimes it takes just more than one surgery. We like to think, oh, we can get it all one and done, but that's not always really the case. Sometimes you need more than one surgery, and if a patient has other issues where they're on a lot of blood thinners, or they have underlying, lung issues or heart issues, which could preclude them from having multiple surgeries, the risk might be too much there. And so those are the kind of patients that don't we would want to just be cautionary with. But for most um, patients, we try to offer everyone reconstruction if we can.
So you try to offer them reconstruction at the same time as the mastectomy, if at all possible.
Correct, because
Just to keep the number of surgeries down because that means less risk for the patient, right?
and also that if reconstruction is done at the same time the mastectomy, you're going to get the best cosmetic results. So I try to do as much as I can at the same time, because then the plastic surgeon's there with me, and we can optimize the amount of skin and the area that we need to, reform the breast contour, the natural breast. If you do it later on down the line, it can just be a little bit more challenging, and you have a little bit more difficulty. It can still be done, but we will obviously want the best result for the patient.
So when you're involved in these mastectomies, what would you say the percentages of people that you're able to reconstruct at the same time as the mastectomy?
Um, for the patients that who elect to have reconstruction, I would say probably over 90% of the time.
Really? It's funny
Yeah.
because I have so many friends who have had reconstruction, and it just seems like, from the cheap sheets where I'm sitting, it just seems like there's reconstruction after reconstruction surgery. It just seems like this elongated process. And literally, I can only think of one person that I know that has had reconstruction at the same time as they had their mastectomy. Do you think that that's common among all breast surgeons, or is that just something you strive for specifically?
I think most breast surgeons strive for that. I think when I say reconstruction, I want to make sure that we don't do the complete, it's like a delayed reconstruction, where when I'm removing the breast, like where we're doing a mastectomy, then a temporary implant will be placed at the same time. So something will be placed then, but then down the line, after the temporary implant is the tissue expander, which they can then fill over time over the next few weeks to match the size of the other breast, or to the size that the patient has desired. And then usually about 3 to 6 months, depending on what's going on with the treatment, the temporary implant is removed, the tissue expander, and then a permanent implant or the patient's own tissue can be placed at that time. So that's kind of what I'm referring to when I say it's done at the same time. And
I
I would,
gotcha.
yeah. Mhm.
Yeah. Totally understand. And to the point of expanders, can you tell us what expanders are? Like if I was to hold one in my hand right now, like what is it? What is it like? And what
It's
does it do? Explain to that if you don't mind.
Sure. An expander is really a fancy name for a tough piece of plastic that kind of it's a pretty round cylindrical shape, and then you just fill it with salt water, with saline, and then that is just more of a filler, kind of what it's saying. As expander, it's a spacer that holds the space where the breast used to be, and then it's letting the tissue around it heal, and let the skin and all of those things heal. As you're expanding, you're going to put tension or stress on the surrounding skin. And so, depending on the healthiness of the skin and the healing, we want that process to take time, so that way we don't have any issues with infection, or any problems with the skin healing along those areas. And they do it gradually as well, because a lot of times the spacer's put underneath the muscle, and as the muscle is stretched, that can cause some discomfort and pain we don't want. And we do that gradually, so it's easier for the patient to tolerate that over time.
Gotcha. That's really interesting. Like I said, I have no concept for any of this stuff as someone who didn't have reconstruction, but I know many of the women watching right now are very curious about this. Maybe as
Sure.
new breast cancer diagnosed individuals, or even people who've had it in the past that maybe just didn't know. It's funny. Speaking of things I didn't know, like whenever I had my mastectomy, and they also biopsied a lot of my lymph nodes, they put a bunch of clips in there, but either they told me and I didn't, and I forgot because it was a time I wouldn't remember well, maybe following surgery or something. And it was like 6 or 7 years later that somebody did an X-ray, and they're like, "Oh yeah," and then you have these clips, and I was like, "What? I didn't know I had those clips in there." And so, are you a person like? Is that part of your job? Like, you go in and you do the biopsies, and you'll leave little clips that are used, I think, to mark what has been biopsied. Is that correct?
Correct. So when you're taking out lymph nodes or you're taking out some of the breast tissue, some of that can be surgeon preference. So sometimes we'll put clips to mark, and I always tell patients don't. They kind of right. They I didn't realize, like you said, as a surgeon, that patients were unaware of those clips, and it was an important thing to tell them because they're like, oh, that's in my body, and we just think it's a natural part of what we do. But the clips can be used to clamp off vessels or some of them the lymphatics, so that way we don't lead to other issues down the line with lymphatic leaks and things and fluid buildup, those kinds of things. But also it communicates in the future for the if you're getting mammograms and things like that, the radiologist can see that there was a procedure done there, and also monitor for any, if they know it's a breast cancer procedure, that if cancer were to come back in certain areas, those clips would kind of tell you where that area was. Because now that the tumor's gone, it's hard to sometimes tell.
Yeah, and I know that like whenever I had my prenatal biopsy done, they put a clip there so that they could note, where the biopsy was done. And then when I had my mastectomy, I got more of the clips, because they did the lymph node testing and everything like that. There was another thing I wanted to ask you about. It just struck me. It was something that I was curious about that has come up a lot. And I don't know if you're the person to answer this or if this is an
Mhm.
oncology question. So certainly just let me know. But you hear a lot of people say that the chance of recurrence is the same whether you have a mastectomy or a lumpectomy. Can you explain
Mhm.
how that's possible?
Sure, this is a very common question, and I always make sure I go through this with my patients, especially when they're first diagnosed, because I think um, it is a difficult thing to understand. So when we talk about recurrence, we talk about recurrence in two different ways from kind of the physician standpoint, a clinician standpoint. So there's recurrence in the breast. So if breast cancer can come back in the breast, or it can come back somewhere else in the body. So when we say it's in the breast, we call it a local recurrence, or in the lymph nodes. So that would be considered local. And a distant recurrence, or would be considered anywhere outside of that area in the rest in another organ of the body, bones, lungs, or things like that. And so when we're talking about the difference between lumpectomy and mastectomies, which I think your question is kind of alluding to, is that when you have a lumpectomy and followed up with radiation and you remove the tumor, the risk of a cancer coming back in that breast is about 2 to 4%, or maybe about 4 to 6%, depending on which literature you're reading. In a mastectomy, when you remove most of the breast tissue, but you're still not removing 100% of the breast because you still have the skin remaining, and so that's also sometimes a confusing point because patients think, well, none of my breast is here. Why? How can anything come back, right? Well, actually, we leave the skin, which is safe to do, and that's still considered part of your breast, and you could have microscopic tissue there. And so we're just checking the skin. So recurrence in the skin of the breast after mastectomy is about 2 to 4%, depending on, also again, those numbers can range. So if you can see the difference between lumpectomy and mastectomy as far as recurrence is pretty much almost equal. You're talking about a few percentage points. And so that's why patients are given sometimes a choice of a lumpectomy or mastectomy as far as treatment, because risk of something coming back in the breast is going to be equal. Now, risk of something coming back somewhere else can be different depending on, the disease itself. Does
That is
that make
that
sense?
yeah, that is interesting. Thanks for spelling that all out for us, lay people. I really appreciate that.
No, that's I
Yeah.
know usually I have some slides and then it kind of makes sense more, but
No, 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 it totally did make sense. But I mean, I'm still just, and I'm sorry to press the question. I'm just
no,
still
no,
curious
I
by
get
it
this all the
because,
time. Mhm.
yeah, because it's like it does seem like how is that possible? Like if if you have more area, isn't it
Mhm.
natural for there to be more area for risk? You know what I'm saying? Like,
Right. Oh
you know what
no.
I mean?
No, I totally understand what you're saying. So this is kind of how I like to break it down. So when you do a lumpectomy and mastectomy, I always tell patients the end goal is the same, is that we're removing the tumor. So as long as the tumor is gone, then that's the end goal for surgery. Now, leaving, and when you with a lumpectomy, you're leaving normal breast tissue behind. And so, how do we prevent something from coming back in the breast tissue? That's where the radiation comes in. So the radiation, um, kind of maybe a little oversimplified, but kind of zaps the tissue, kind of takes care of any abnormal cells and makes sure that they break down and don't, and there's not anything there to kind of giving you any area for things to grow again in that space. And so that's why I always tell patients, between lumpectomy and mastectomy, survival is the same, unless you have some kind of, pre-existing genetic mutation or, family history that can throw things maybe a little bit different there. But for the most part, lumpectomy and mastectomy patients will have equal survival. So that's why the choice that you're making isn't a medical decision. It's more of a personal one about you want how you want to live with after surgery and how you want to see yourself, with your breast or without it, after all of this is done. That's how I kind of approach it. It's a personal decision, not a medical one.
So there's never a situation where you're like, "Oh, you should get a mastectomy."
Well, so to
Here it
there
comes.
is all
There
right,
is
right,
one.
hold on. There is one. So the lumpectomy patients are a good candidate for lumpectomy if the tumor is small enough that when we remove it, we're not leaving an overly large defect, right? Because we don't want if we're if the tumor's big enough where to remove it, we're taking about 50% of your breast, half of your breast. Well, then it's not going to be a very good cosmetic outcome, right? So we don't want to do that. So in patients where the tumor can be bigger, and it just depends on a big tumor in a smaller breast, probably going to lean towards mastectomy. Or there's certain inflammatory breast cancer, that's where you'll be more likely to do a mastectomy. Locally advanced cancers, bigger cancers, bigger burden, then you're not going to be able to do a lumpectomy. But with good screening and mammogram, we find a lot of these tumors really early. Early breast cancers, definitely lumpectomy is a good option. You lean more towards mastectomy depending on the size of the tumor or the amount of disease.
Okay, you are slaying it. I want you to know this is such
Oh,
awesome
thanks.
information.
Oh,
I'm
well,
so
great.
excited that everybody's getting to hear this, and I'm also excited that we'll be able to have this up on our Facebook as well as on our YouTube channel in a couple of weeks. So I'm very thankful that everybody will have this for reference. So when I think about this stuff, so I'm thinking, you hear about all these people who do this preventative mastectomy.
Mhm.
What is your feeling about that?
Well, I think there's definitely it's an individual choice, and preventative depends more like on your risk. So if you have a family history of breast cancer or you have a genetic, mutation and you're a carrier and that increases your risk of breast cancer, I think preventative mastectomies are definitely a good option and very reasonable to do. Um, but then preventative mastectomy, let's say if you have breast cancer in one breast, and then should you, which is a question I get very often, should I, take the other breast as well at the same time? So in that case, if there's no, um, you know, genetic mutation or things like that, I find that that's more of a personal um, decision. Because from a medical standpoint, there's really no data in that setting that you're going to live any longer because you've removed the other breast. Because really, the focus when you have breast cancer in one side, then the focus is on getting rid of that cancer. I always tell patients, look, I am worried about the cancer that you do have. Your chance of having a cancer on the other side, that's kind of a risk we haven't gotten to yet. Does that make sense? Because, I'm not worried about the cancer you don't have. You know what I
Yeah, that
mean?
totally makes sense. No,
Right.
thank you for explaining it so candidly too.
Right. So, but definitely, if it gives a patient more peace of mind,
Right.
if they're looking for, symmetry, or maybe they just had really fibrous, breast tissue, and they keep telling me, gosh, they always call me back. It makes me worried. I'm always getting biopsies. So there's
Right.
different reasons, to do that. So I don't want to ever say, what the right choice. The right choice is what works for the person.
Yeah, and like we always talk about in any of our broadcasts is that everybody is so different and every situation
Right.
is so different. You can't just do some blanket whatever. But I really am glad that you kind of lay that all out because it's very interesting. So if you have a patient like like that doesn't have any genetic mutation, they've done all the genetic testing and they have breast cancer in one breast, and that's all. Let's say that's all you knew. Then based on what
Mhm.
you said, you would try to do a lumpectomy unless it was over, 50% you're gonna have to take out. If it was over 50%, then you would do a single mastectomy. If they didn't have any mutation, there would be no reason to do a double mastectomy. Is that pretty? Have I learned
Right.
a lot
That
yet?
right. You did. That was actually
Woo!
really
Yes.
good. That was.
I feel like a pro now.
You are. And then, of course, there's variation along lines. And actually, uh, the rule of thumb that we use is about 25%. So if it's going to be over 25% of the volume of the breast, then that's where lumpectomy can kind of be a little borderline. But there's room. Every person's different. But yeah.
That's very cool, and I have so many questions. It feels like we might need to do the lightning round. There's some people in
Oh,
the
okay,
room
sure.
that there's some people in the room that have some questions, and then I have some other questions that I just wanted to make sure to get to. And I know this is true in a double mastectomy. It's never possible really to remove 100% of the breast tissue, right? Because there's always going to be some
Correct.
left behind, right? Okay,
Right. Like a few percent. Right.
right,
The
right.
skin. Yeah.
Yeah. And my question, personal question, and this is also for any of the other folks out there that have gone flat, is if you've gone flat and you've been let go, like I've been let go from Dr. O from after 8 years, she's like, hey, you're good to
Sure.
go, or whatever. Is there, I never honestly think about doing like self exams because I don't have breasts. But I should probably be feeling around like in my armpits and around on my chest and things like that, right? Doing some form of self examination because they don't do mammograms or ultrasounds or anything on me anymore.
So I tell patients, you don't, I know there was that big self exam movement where, everybody should examine themselves every month. And so we're kind of getting away from that because we've realized we kind of made everybody really anxious every month. And so, meaning that, sometimes it's hard. You don't know what you're feeling. You're not sure if this is a mass or not. I get that, those questions and concerns a lot. So what I tell patients is, if you're in the shower and this is an easy place, you're just washing, that's a just good time to have some awareness, meaning like, everything feels normal, great. But a lot of times when patients feel something or have a recurrence, I most of the time they just kind of have this feeling like, oh, I felt something was wrong there. Or you know what I mean? There's that voice in your head. So if you ever have that voice in your head tell you, hey, something's not right, then I always tell the patient, come on in, let me look at it and see. Because I feel like patients always know themselves a little bit better. And you know your body. And when something's not right, it just kind of somehow just comes out. You know what I mean? It doesn't have to be like a separate thing you do every month. This can just be something normal in the shower, just being aware of what's going on. When you're, washing under the arm, around your chest, and things like that. And if everything feels normal, that's great. Don't worry.
That's very good advice. And I know, in fact, that there is one breast cancer survivor watching right now that had that. I just feel like something's not right, and that's how
Right.
she found her breast cancer. So I think that intuition that we all have, you should always listen to that for sure.
Yes.
We had a question about when a patient chooses reconstruction, do the implants go under the muscle, and what side effects might be felt as a result of that?
Oh, okay. That's a great question. So the Standard before, most of the time, the implant was placed underneath the muscle. So there's a movement now where some patients or can have the implant placed above the muscles. So it's a little bit of plastic surgeon preference and also the patient. So putting the implant underneath the muscle will cause a little, that's going to be make the muscle sore. You're going to stretch out the muscle, and over time you'll get used to that, and the muscle adapts. So the downsides of putting it underneath the muscle is that when you do, it's going to be skin, muscle, then implant. So the skin is really what gives you kind of hides the implant, so to speak, with along with the muscle. But if you are moving your chest, or if you work out a lot, those patients tend to say you get what we call animation effect. The implant will move up and down. And so a lot of times patients don't like that if you work out a lot. So that's where sometimes patients will go, I had it underneath the muscle. I think I'm going to move it above the muscle if you can, to avoid those kinds of things where they can see, your breast is moving, or it'll kind of cause this movement of the implant. So patients don't like that. Sometimes you'll get a little bit of rippling, but those are the most common ones.
Wow. Interesting information. We also have a person in our chat room right now, Mary. She says, my sister passed away at 39 from metastatic breast cancer, and my mom is a post-menopausal survivor. I think, I'm not sure if that's what she meant, but I am BRCA1. It says 1 through 2 negative. What is my breast cancer risk? So I guess BRCA 1, 2 negative.
Right. So sounds like she tested or did some genetic testing and it was negative. So I don't know if I can give you a specific number, but I would say is because you've had, your mom and your sister, if I'm correct, that the genetic testing is great if we can find something or something that we know about. But if you do have close family members like in her situation, I would still say she's at probably higher risk than average for sure. Somewhere in that kind of around 20 to 30% sometimes. But again, a little bit more history on all those kinds of things. But I would say she would definitely want to start screening at least 10 years earlier than the youngest person that was diagnosed in her family. So let's say if her sister was, diagnosed, I forgot the age, but let's say her sister was diagnosed at 40, then she should start some kind of screening or follow-up at 30, if that makes sense. So,
Gotcha.
Or if the youngest person in your family was 50, then you would start at 40, which is normal, which is the common age.
Well, I have to say, Dr. Dao, I wish I could take your brain and dump it on a table so that I could just pick through and grab all the information, because it's so
you're
good.
So sweet.
You're so good. I'm going to steal you for just a few more minutes if you're okay with that.
Sure.
We have a few more questions. I know it's 8 o'clock Central Time right now, but I want to get a few of these other questions in here. So this comes from Jennifer. She says, if you have a lumpectomy and you have a local recurrence, is that considered a metastasis or a new primary cancer, or could it be either one?
So when you've had cancer and then something comes back, a recurrence, usually we consider a recurrence within, I'd say maybe 10, 15 years. But now, breast cancer patients are doing so well that they actually, I've seen recurrent, if you get something back maybe after 20 years, I've seen that. It could be a new primary, but most of the time, if it comes back in that breast, we would consider that a recurrence and not a metastasis. Metastasis is the word we use for cancer that has moved away from the central source. So if it's breast cancer and the cancer is in the bone, then it's in another part of the body away from its source. So that's a metastasis. So
Gotcha.
Does that kind of help?
That does. I think the one question in there that I was noticing is that she said, considered metastasis or new primary. So I think, isn't it possible that you could have one type, like say you had triple negative breast cancer, okay, and then that's all taken care of, you're told you're cancer free, and then 5 years later you have a new breast cancer and it's HER2 positive. That would be a new primary, right?
Correct. So, wow, you've got it down.
Saying, dude.
So, yeah, I was like, I didn't know how technical, but you're right. No, definitely. So, recurrence would be if the cancer that came back or what they found is similar to the primary, meaning the initial one that you had. So, if it's the same subtype, then that would be considered recurrence. If it would be considered a new primary because it, like you said, it was a different subtype. So then we know actually this is not the same kind that was there before. This is a whole nother cancer.
Yeah,
Correct.
yeah,
Right.
and I've actually known a few people, I mean, a
Right.
lot of breast cancer survivors, obviously, in my position, and I've known several people who have said that they had a new primary breast cancer that was not
Right.
the same makeup as the other one, which is very
Right.
interesting. Um,
It's very rare. Yes.
yeah, it's
Right.
crazy. Irene has a question here. She says, "I had a lumpectomy after ACT for TNBC. Will the skin and breast tissue stretch so the breasts are closer in size?"
Hmm. Okay. So she's saying she had
A
the
lumpectomy.
chemotherapy, a lumpectomy, right? And
After chemo. Yeah.
she's wondering if the skin will stretch
Yeah.
to match the other breast. Not without some kind of I would say you would need either like an expander. That's where the skin would stretch, or I'm not sure if she means that over time as she gets older, your skin will stretch out. But after a lumpectomy, you'll usually go on to have radiation, and the radiation will cause the skin to kind of almost shrink, but it doesn't necessarily shrink, but it looks like it has. Because what happens is the skin tightens up, and so, since the skin is the envelope that kind of holds our breast, it's going to make it look maybe 10 to 15% smaller. For some patients, it can be a little bit more. And so, I think she might be asking, is that going to maybe get better over time? And it might with, you can do some physical therapy massage to kind of help decrease that radiation change. I always recommend, I always tell my patients to use a lot of aloe vera or lotion daily to help combat and let the skin heal, to help the skin, because a lot of skin care actually, because the radiation is like a burn to that skin, and the skin will continue to really try to heal itself for not just those weeks or months after your treatment, but really it goes on for years really, and it'll continue to get better and tend to, as long as we take care of it, it can start to normalize and kind of match the other side. Or that's what that's the goal.
Very cool. Thank you for that. And thank you for your question, Irene. I have about three more questions for you. I'm going to try to snag you, and then we'll have Gina on. Gina is a stage 4 breast cancer survivor, joining us immediately following Dr. Dao here, who is a breast surgeon here in Texas Oncology. So thank you so much again for being here, Dr. Dao.
Oh, you're welcome.
Couple of quick questions here. What is the percentage of patients who choose to go flat? And is that healing process easier than that of reconstruction?
Oh, that's a great question. I would say about, I would say 10% of patients, of mastectomy patients, probably choose to go flat. I mean, there's some, variation. And then is that process easier? Actually, it really is easier because the the good news about the breast is it's a lot of soft tissue. And so when you're removing that tissue, you're not really interfering with the muscle and things like that. So patients tend to have a lot less pain. And also, once we remove the breast tissue, that area tends to be numb, because once we remove that breast tissue away from the skin, you're cutting through those nerves. And so a lot of times patients don't really have a lot of feeling. And so and that's a little bit of an advantage as far as we're talking about, pain and recovery time. So I tell patients usually after a mastectomy, 1 to 2 weeks, and they may be a little sore that first day. And if they had a sentinel lymph node biopsy, that's going to be probably the sorest spot for them. But usually they're backing up to their normal activities. It's really fatigue that when we talk about recovery, that is the issue, because you'll be able to do everyday activities. It's just you'll feel really tired. The first week you'll be at 80% of your energy. And then, the next week you'll be like 90, 95. And so that's what we're talking about when we talk about recovery.
So do you feel that it's that it takes, from the people I've talked to, the recovery process from reconstruction has been a lot longer in general
Correct.
than that of just going flat. And obviously, going flat, the surgery is probably a shorter surgery. And oftentimes, you don't have to have follow up surgeries unless there was some issue or something like that, right?
Correct. So I would say it's about half. So if it without reconstruction is about 2 weeks for a patient with reconstruction, a recovery is about 4 to 6 weeks, depending on what you have. And like you said, right, there can be more surgeries down the line. And so that's going to add on time and those kinds of things. So it is easier to have no reconstruction. So if patients are looking for, you know, the thing that will be the easiest for them to get back to their everyday life, I tend to say, then no reconstruction would give them that if they're looking for mastectomy, with or without reconstruction.
Gotcha. And I mean, would you go as far as saying that having a mastectomy without reconstruction is a lower risk thing to do than having the reconstruction because you're going to have less surgeries overall? Because we were talking yesterday, I was telling you that I was surprised to learn that usually with reconstruction, you actually have to come back and have them redone periodically every 5, 10, or whatever, how many years. I don't even know how many, but you have to come back for further surgeries. So the more surgeries, the longer surgeries and things like that, that's higher risk situation than just having a mastectomy without reconstruction. Would you say that?
Correct. Yeah, I would say that. And that's where, when we were kind of back to that earlier question, when we said, who is a good candidate for reconstruction or not. So, really healthy people are better candidates for reconstruction. But like I said, mastectomy has less risk of complication, infection, things like that. Because, with an expander implant, it's a foreign body. If that became infected or issues, those are things that you have to be addressed. It's very rare, but they're less likely, but they can happen.
Right. Thank you for that information. This is powerful stuff. This is the kind of stuff that gets asked all the time, Dr. Dow, on all the Facebook groups out there. Like
Oh,
all the breast cancer survivors, we're out there spinning
yeah,
around and we just don't know the answers to these things. And this is really powerful information. And we did have another question. It was
sure.
from Jennifer. She says, should patients with mastectomy/implants continue to have mammograms?
So the I would say no. I always tell patients who get a mastectomy, the good side is you don't have to do any more of those mammograms. Yay. So,
Mm.
because the reason is because we've removed most of the breast tissue. And like we were saying, the only part of the breast that's really remaining is the skin. And so you could have a mammogram. I'm not saying it's not possible, but you don't need to have one. And because we can do an exam, if something were to come back, it would come back in that skin layer. And so it's something that you could feel, or if there was something that we're concerned about, I usually use ultrasound. MRI can be used as well. Some clinicians will use it, but I find it's sometimes harder to localize where it is because it's such a broad a modality or imaging study, where ultrasound is more kind of focused and clinical exam and those things.
Very cool. Again, amazing information, Dr. Dow. There's a lot of people here. I want to give a shout out real quick. We've got William is here. Josie is here. She says, Dr. Dow, you are top shelf.
Oh,
She's right, dude.
she's awesome.
William says,
Thank you.
William says, positive mental attitude, PMA, Wildman Bill Martin from Florida in the house. Amy says, thanks for doing live videos. Amy, we are here for you, girl. Totally. We had a few other people. Ray was here, Irene, Mary, Jennifer, a lot of people in the house tonight. I want to thank everybody for sharing the broadcast. Continue to share that because we're going to have Gina, who is a stage 4 breast cancer survivor, coming up next. Dr. Dow, I cannot thank you enough for hanging out with us tonight. I really appreciate it. And like I mentioned earlier, this interview with you will be up on our YouTube channel at youtube.com/breastcancercanstick. That's youtube.com/breastcancercanstick. We'll be up there within the next week or two, and you can watch a replay there, or you can watch the replay right here on our Facebook channel anytime as soon as this broadcast is over tonight. I want to thank you one more time, Dr. Dow. Everybody give it up and throw some hearts in the house for Dr. Dow. Woohoo!
Oh, why, thank you. It's a pleasure to be here.
Yeah, thank you so much.
Thank you. It's wonderful.
Yeah, we'll talk to you real soon. You take care, okay?
All right, you too. Bye-bye.
All right, everybody. Dr. Dow, that was amazing. Amazing having her on this evening.